So we are starting with case number 34 of ODELL, which is white lesions on the buccal mucosa. And this is in continuation of learning about lesions in the oral cavity. Now, this is a 55-year-old Afro-Caribbean woman presents to you with a complaint of sore mouth. You make a diagnosis and institute treatment. So this kind of right and left buccal mucosa, right side, left side. Patient complains of occasional soreness on the inside of her cheeks and white patches on the inside of her lips. The patient first noticed a burning sensation 3 months ago. So it is associated with burning sensation also. She notes that the soreness is brought on particularly when she eats sour and mildly spicy foods. She had noticed that the white patches on her lips started around the same time, and she thinks these patches are spreading. So it has an association with sour and spicy foods too. The patient is generally fit and well, not any current or recent medication. It's a very important thing to look into when one is talking about lichen planus versus lichenoid reactions, whether patient is on medication or not. She has never smoked and consumes less than 5 units of alcohol a week. Again, a very distinctive feature in ruling out other diseases which can be related to smoking and alcohol. Like we read in leukoplakia, there would be somewhere to make up the case, there would be a history of smoking, tobacco, carcinoma in situ. In these, it would be present. Then we have the patient appears fit and well, no rashes on face, no cervical lymph nodes are palpable. So rashes on face, they would be far more present in autoimmune diseases like SLE, rashes, mucosal and skin rashes. So one of the features would be rashes on any other area of the body, and white patches were visible on the upper lip. Now, the mouth is well lubricated with saliva and the patient has good oral hygiene. So this is, again, not a xerostomia or not a condition wherein plaques can form because of the dryness of the mouth. There is no discoloration of the occlusal surface of lower posterior molars and only minimal occlusal amalgam restorations. So occlusal amalgam restorations minimal is present, and if amalgam restorations are present, we have to typically associate it with these lesions on the mucosa. If it is on alignment with the amalgam restoration, it would be more diagnosed as a lichenoid reaction versus lichen planus, depending upon if any restoration contact is there or not. Then we have, there is discoloration of occlusal surface of lower posterior molars and only minimal occlusal amalgam restorations. Appearance of the left and right buccal mucosa is seen. And how do we describe this? Buccal mucosa is affected bilaterally by the reticular white striae and associated poorly defined diffuse brown pigmentation found mostly at the periphery of the striae. The white striae extend from the posterior buccal mucosa to the commissural region. In the left buccal mucosa, there is a central solid patch of white mucosa. Then poorly defined striae are seen in the right soft palate. In the right buccal mucosa, the white appearance of the buccal mucosa is most prominent in the occlusal plane. So in the occlusal plane here, we see quite a significant, it is coming in the actually in the biting region. Then poorly defined striae are seen in the right soft palate, right buccal mucosa, most prominent in the occlusal plane. There are no obvious right red patches and no ulceration. So what is your differential diagnosis? The three main lesions which are your differential diagnosis are lichen planus, lupus erythematosus, which could be SLE or DLE, systemic lupus, where the patches would be seen in systemic areas, or discoid ones, where the patches would be roundish, discoid, disc shaped. And then lichenoid drug reactions, it would be always associated with some drug history. Now, moving on to studying these differential diagnoses. The combination of the reticular and diffuse white areas on the background of slight redness almost certainly indicates one of the three conditions. The lesions cannot always be diagnosed by their clinical appearance alone, although there can be some differentiating features to each of the condition. But whenever you spot these lesions, which are like having this striae kind of a spreading, okay, reticular pattern means there will be a central area and like a star rays will be going on. So that is always either a lichen planus or a lichenoid reaction. Okay. Then the condition is commonest of the three possible diagnoses. It is the commonest condition and most prevalent in women in their 5th and 6th decades of life. So how old is this patient? 55, correct, matching with the lichen planus age, and it's a woman. Then the most prevalent in women, 5th, 6th decades of life. The striae and the lacy patterns on the buccal mucosa are distinctive of the lichen planus and typically bilateral. Lichen planus can also cause white patches on the lip and palate, as in this patient, although this is less common. Then we have lupus erythematosus. The mouth may be involved in lupus erythematosus, either as a part of SLE or in DLE. In both conditions, clinical features of oral mucosa resemble those of the lichen planus and lichenoid reactions. But some findings may help in the diagnosis. And lupus erythematosus is more frequent in females, and there is a higher prevalence in patients of Afro-Caribbean ethnicity. Lesions in LE often have a central ulcer or erythematous area around which the striae tend to radiate, rather than follow the random pattern of lichen planus. So we have this Afro-Caribbean ethnicity, which is seen in this patient. It is more found in lupus erythematosus. That's why it's differential diagnosis. And in here, there would be a central ulcer or a reddish central area, and then the striae radiate, rather than follow the pattern of lichen planus, which is typically of the white area spreading into, like it would be a white star, central area and then spreading striae. However, it is in lupus, it's a ulcer or red area, erythematous, and then striae. Lesions are also typically asymmetrical and affect hard and soft palates, which are less frequently involved by lichen planus or lichenoid reactions. So typically, lichen planus is seen in buccal mucosa. In lupus, it is hard and soft palate involvement is common. LE is means lupus erythematosus is much rarer than either of other two possibilities, but unilateral involvement of the palate and lip involvement, as well as patient's ethnic background, indicates that LE should remain a consideration in this case. Why we are considering this? It's though a rare occurrence and it's an autoimmune disease, it would be having some visibility, some appearance, and some history in other areas of body also. There are more chances of lupus affecting systemically than just oral lesions, whereas lichen planus is typically oral lesions. However, because in this patient, she is Afro-Caribbean, this patient has lesions on the palate. That's why we should keep it as a strong differential diagnosis. Last we have is lichenoid reaction. Oral lichenoid reactions may be localized in response to topical triggers, such as restorations or more widespread, in which case they are usually caused by medication. Some features that point to a lichenoid drug reaction rather than lichen planus include acute onset, extensive ulceration, asymmetrical distribution, and severe involvement of the dorsum of the tongue. So what is the major difference between lichenoid drug reaction and lichen planus is that there is a topical trigger or there is a medication trigger to it. And this is lichenoid drug reaction would include acute onset. Extensive ulceration would be present in such circumstances, and asymmetrical distribution and severe involvement of dorsum of the tongue. The dorsum of the tongue would be completely severely involved. Lesions may also affect sites that are less commonly affected by the lichen planus, such as the floor of the mouth. Lichenoid reactions may be clinically indistinguishable from lichen planus. In this case, a lichenoid drug reaction can probably be ruled out because the patient is not on any medication. Although double-checking recently discontinued prescriptions and over-the-counter drugs is necessary to be certain. So if we do not find any medication, any amalgam filling in that associated region, it should not be lichenoid reaction. The location and distribution of the lesion do not correspond to any dental restoration, so a topical lichenoid reaction can be ruled out. Then how do you explain the darker pigmented areas? These blackish areas, why they are present, this melanin kind of areas, okay? The combination of white patches and striae with pigmentation is potentially confusing, but the pigmentation is a secondary effect called inflammatory or post-inflammatory pigmentation. In diseases where the epithelium is damaged or becomes inflamed, melanin pigmentation formed by melanocytes in the epithelium fail to transfer into epithelial cells. So these melanin pigment is not contained in the epithelial cells. It drops out into the connective tissue. So that's why it becomes darker. It appears visible on the mucosa. Here it is recognized as a foreign material and phagocytized by macrophages and only slowly degraded, producing patchy brown discoloration. So it remains for a while. It takes a long while for them to get decomposed. That's why it is patchy brown discoloration. Inflammatory pigmentation is usually seen in dark-skinned individuals. What further questions and examinations are appropriate? On further questioning, the patient reports an itchy rash on the flexor surface of her forearms. So there is a systemic lesion and itching surface in there and shins which developed around the same time as her oral white patches. Her rash is consistent with cutaneous lichen planus, which typically presents as raised, itchy red-purple lesions. She has never had a facial rash and she reports no other symptoms. Rashes in lupus typically affect head, neck, and sun-exposed skin. So that's why it's a differential diagnosis strong, because even the lichen planus, the cutaneous variety, she's having some rashes on shins and the forearms. Is biopsy indicated? Definitely, yes, because biopsy should be performed in the majority of white lesions in the mouth, especially if the patient reports high alcohol or any tobacco consumption. Here, in her case, it is not there, but still it is a long-standing lesion, and anyways, it's a precancerous condition. When there is extensive mucosal involvement, ulceration or atrophy, or when the clinical presentation is not typical, other condition needs to be excluded through biopsy. For example, in this case, lichenoid reactions and LE. It is not always possible to distinguish between these three diseases histologically, but microscopic characteristics may help favor one of these three entities. Histological features always need to be interpreted within the context of the clinical presentation and the results of other tests. A biopsy is also useful to exclude unexpected diseases, particularly dysplasia. Proliferative verrucous leukoplakia and other potentially malignant disorders can be misdiagnosed as lichen planus. So here it is one of the differential diagnoses relating to varicose leukoplakia also, and other potentially malignant means red and white lesions and lichen planus are associated, particularly when the lichen planus forms plaques rather than the striae. Further reason for biopsy is that lichen planus itself is considered to have a very low risk of malignant transformation. So it in itself bears the low risk of malignant transformation. For this patient, incisional biopsy is indicated. Okay, what are the questions you would ask in information gathering from this patient who is having these oral lesions and rash? Is rash present? The patient should be questioned about any skin, nail, scalp problems and about any genital symptoms. So we commonly ask if there are any rashes, similar lesions in any other part of your body. Ask about and examine in the flexor surface of wrist and extensor surface of the shins. Flexor is inside, extensor is outside, which is when we do flexion, this closes, so inside surface of the wrist and extensor of the shins, outside of the shins. These are commonly sites for skin lesions of lichen planus and lichenoid reactions. The typical skin lesions of lichen planus are purplish polygonal papules with faint striae, which is the Wickham striae. They are usually very itchy. Severe lichenoid reactions may be accompanied by an extensive erythematous rash. Only a minority of cases with oral lichen planus or lichenoid reaction will have skin lesions on presentation. This is because skin lesions often resolve spontaneously after a few years or with topical steroid treatment. So, oral lichen planus and lichenoid reaction will have less chances of having the skin lesions. Then we have, in contrast, oral lesions may persist for many years and often resistant to treatment. Therefore, ask about previous rashes on the skin. Skin lesions of SLE are different from lichen planus and may be of several different types, including discoid rashes, erythema nodosum, and other more non-specific papular erythematous and blistering rashes. Rashes in DLE are often confined to the face, neck, and scalp of the hands and may also be affected with sparing of the knuckles. Typically, the face is affected by a butterfly rash on the malar region of the face. Rashes elsewhere on the body tend to be photosensitive, so are worse on sun-exposed areas. Signs and symptoms of SLE. Although it is a less likely diagnosis, the patient should be asked about some questions to exclude systemic involvement. Questioning and examination should be more thorough if oral lesions suggest lupus erythematosus by virtue of their appearance, distribution, or the young age of the patient. SLE has numerous signs and symptoms, including rashes, photosensitivity, and hair loss. Vasculitis can affect most organs. There may be glomerulonephritis, arthritis, anemia, and central nervous system involvement causing infarction and or psychiatric manifestations. The patient should also be questioned about symptoms of fatigue or arthralgia. So this is a common thing that we should also ask about, because these are autoimmune diseases, right? SLE. So we have to ask about any other manifestations which are more of like glomerulonephritis, fatigue, arthralgia. They are typically of the, again, autoimmune kind of a nature where immunity fights on the body's own cells. Then what part of the lesion would you remove for biopsy? It should be taken from the most clinically representative area, including both red and white areas, if they are present. If there is ulceration, it should be avoided because epithelium is required for diagnosis. So if epithelial lining is missing as in ulcers, we would avoid that area, and there will be florid inflammation masking the histological features in the ulcerated area. Other investigations, what would be needed? Autoantibody screen, which is seen in SLE, microbiological tests to rule out candidal infection, and other tests like patient has oral, mucosal, and cutaneous involvement. She may be a candidate for systemic medical management. Therefore, baseline renal and liver function tests may be needed. So referral to the general physician would be also very much required in these patients who are having these associations of all these conditions. And in the biopsy specimen, where what here we will see is well demarcated inflammatory infiltrate, as we can see it here, and a band infiltrate in a band immediately below the epithelium within the superficial connective tissue. So this is the epithelium area, this is the connective tissue area, and here we find a lot of inflammatory cell infiltrates. There is the band is denser towards each side of the picture. Lymphocytes have infiltrated into the basal and suprabasal layers of the epithelium and caused the basal epithelial cells to undergo apoptosis. So this is the epithelium low power view, and it's the high power view here. And this is the still higher power view. So here, if we find the basal membrane cells, they are more apoptotic. This is the lymphocytic infiltration, significant in the basal cell layer of the epithelium. There is no remaining clearly defined basal layer of epithelial cells, and the cells lying at the basement membrane have the appearance of prickle cells. The surface is parakeratinized. So how do you interpret the histological findings? A dense band-like infiltrate of lymphocytes, that shows it is an immunity-based condition. It's not just a lesion like leukoplakia, where there is less role of the immune cells. It's more of the growth of the cells. It is going towards, leading towards the cancer zone. Whereas lichen planus, though it has minimal cancerous potential, but more or less we would say it's an immunal. When we check the histopathology, it's more governed by high lymphocytes and high infiltration of these cells, which makes it more immune condition. That's why these can be in the later stages treated with the steroids and stuff, but there it is cancerous, tobacco cessation, in leukoplakia, in carcinoma in situ, those levels of things work. The dense band-like infiltrate of lymphocytes, lymphocytic infiltration of basal cells with focal basal cell degeneration, apoptosis, loss of basal cells, and a thickened basement membrane are typical of the lichen planus. Other results, in this case, autoantibody screen results was negative, and no candida was found in the saliva or biopsy sample. The full blood count as well as the hematinic, renal, and liver function screened results were normal. What is the diagnosis? The final diagnosis in this case is lichen planus with oral and cutaneous involvement. The lichenoid reaction has been excluded because the patient is not on any medication and the distribution of the lesions do not correspond to any dental restorations. The cutaneous findings are not typical of lupus erythematosus, and autoantibody screen was negative. What are the treatment options of this? These are the 4 major treatment options. Analgesic relief. Okay, let me first complete that. This lesion, other options were excluded. Diagnosis of lichen planus is made. despite unusual distribution, because it should not, it's very rare to have lichen planus on palate. That's why they say, despite unusual distribution, diagnosis is lichen planus. Then what are the treatment and how would we manage? This is the table for the treatment. Analgesic relief. So topical benzidamine is the case we use for relief of any oral painful lesions. So it's an NSAID agent, provides temporary analgesia to the oral mucosa. It can also be useful prior to toothbrushing to help maintain good oral hygiene. Topical medium potency corticosteroids. So they can be prescribed in the form of mouthwash, spray, ointments, or in the form of aerosol inhalers used for asthma. This option would be mainstay treatment for most patients with mild to moderate symptoms. Options include beclomethasone inhaler and betamethasone mouthwash. Then topical high potency corticosteroids. These high potency drugs, such as clobetasol ointment, should be considered for more severe or generalized conditions. In general, this option should be provided in a secondary or tertiary care setting. And then we have systemic corticosteroids. Systemic corticosteroids like prednisolone and disease-modifying agents, example, hydroxychloroquine, azathioprine, mycophenolate, mofetil, are used for severe cases that do not respond to topical treatments and should only be used in a secondary or tertiary care setting. Regular monitoring for the adverse effects of these drugs is needed. So we have analgesic, benzidamine, topical corticosteroids, systemic corticosteroids, and topical corticosteroids are of two variants, medium potency, high potency. Okay, so these is the treatment options, what we would do. Now, gingival lichen planus, where it is most aggravated, can be most aggravated by plaque. It mimics severe degree of the gingivitis actually. And in some patients, maintaining optimal oral hygiene can be difficult because of the pain. Patients should be helped to maintain a high standard of oral hygiene. Some patients also find the detergent sodium lauryl sulfate in certain toothpastes an irritant, and they should switch to an SLS-free toothpaste. So highly flavored toothpaste should also be avoided. And in this case, oral symptoms were managed with 0.5 gram betamethasone dissolved in, it's a steroid, dissolved in 5 to 10 ml water as mouthwash for 2 to 3 minutes up to 3 times daily. The patient was referred to her general medical practitioner for the management of her skin lesions. And so referral to GP is must for skin lesions. At the review appointment, patient reported that she was much more comfortable and oral symptoms were under control. What considerations you would take into account when determining frequency of follow-up? It should depend on whether or not systemic medication has been prescribed, because there may be adverse effects and we need to monitor them. There is also a low risk of malignant transformation, oral lichen planus. Oral lichen planus is a precancerous condition. There is controversy surrounding the exact rate of malignant transformation, but it's less than 0.1%. And some authorities suggest malignant change is more common in non-reticular form, where that reticulum formation, that stria formation is less. Basically, the verrucous variety, the nodular variety of lichen planus. Lesions in high-risk site, which is floor of the mouth, should be monitored. Also, the lateral border of the tongue, again, is a high-risk site. The soft palate behind of the mouth is a high-risk site. Patients should be instructed to look out for changes in clinical appearance of lesions. Any ulceration, any changes in the surface texture is a red flag signal of changes in lichen planus. So this completes our lichen planus lesion from ODELL. Any doubts?